Okay. So, I will be talking about Treacher syndrome and Stickler syndrome. So, what we'll do is I'll talk about Treacher's and then Stickler syndrome, and then at the end we'll do a case and kind of decide which of the syndromes it is. So, let's get started. For Treacher syndrome, for the etiology and pathogenesis, it's a autosomal dominant disorder that affects the craniofacial development. So this means that each parent has to be a dominant carrier of the syndrome in order for their child to have this syndrome. This autosomal dominant gene is seen as a mutation called TCOF1, which according to Trainer et al. Is a low complexity serine alanine rich nuclear protein called treacle. I think I pronounced that correctly. This gene is about 81 to 93% of the cases that are seen, with about 2% of cases being from a gene mutation called POLR1C and POLR1D. Of note, POLR1C is an autosomal recessive gene and would take 2 recessive genes for the gene to be expressed, so meaning that the parents both need at least 1 recessive POLR1C gene. And also these parents could not even be presenting the symptoms of the syndrome as well. So how do these genes ultimately cause this syndrome to take place? These genes produce certain proteins that are integral to the early development of tissues and bones of the face. So these proteins are used to create ribosomal RNA, or rRNA, which assists with providing amino acids into new proteins that help cells stay alive. These mutations in these genes can limit the amount of rRNA produced, which can lead to apoptosis of the cells that are necessary for bone and tissue development. This rRNA reduced production affects the first and second branchial arch in embryo. So just flash back to hearing disorders. The first branchial arch forms the external auditory meatus, the middle ear cavity, the mastoid atrium, and the eustachian tube. The first and second branchial arch is also where the ossicles begin to form. It's still unknown, though, as to why this phenotype is only expressed facially. There are also multiple mutations that are associated with TCOF1 that seem to be family specific because of the homogeneous nature of the gene that is seen throughout families. However, on the contrary, 60% of the cases observed with Treacher syndrome are de novo, so meaning that it is a new mutation that is not seen through family history. This demonstrates the high variability and severity of phenotypes throughout families and individuals. So for epidemiology, the prevalence for Treacher syndrome is 1 in 50,000 live births. However, as I mentioned before, of the high variability of symptoms presenting, the prevalence could be a little bit more because of the cases that are not documented or not diagnosed, because they're so mild that they kind of fly under the radar. So that's something to consider when looking at the prevalence as well. This is also a congenital syndrome, which is diagnosed at birth or soon after if symptoms are presented. And it's also not gender specific. So here's just a picture of a little cutie with Treacher on the side. So for the phenotype for Treacher Collins, it's very specific facial characteristics or phenotype that is expressed. So these craniofacial anomalies are targeted around the head and neck region. Hypoplasia of the facial bones, meaning underdeveloped facial bones, which could cause a flat appearance around the mid-face region. An underdeveloped zygomatic complex is essentially your cheekbones that have not been fully developed in utero, so it appears flat. Dental malocclusion, meaning that the top row of teeth and the bottom row are not aligned, which results in either an overbite or an underbite. High arched and occasionally cleft palate are also seen in some of these patients. They also present with downward slanting eyes and notching of the lower lids, meaning that the lower lid has a dip down, kind of like a noise-induced hearing loss. The external ears are different in shape, position, and size. The ear canal can either be atretic, so closed ear canal, or stenotic, very small opening or small canal. Ossicular chain is disrupted, irregular, or absent. These patients' symptoms are always symmetrical, which is extremely useful in differential diagnosis. Generally diagnosed with Treacher Collins is based on how these types of phenotypes are presented. However, any and all of these that are listed can be presented in mild to severe forms. So it's extremely case-by-case situation, and because of that, it's important to obtain genetic testing as well. And also to note that there is no cognitive disability in these patients. So here are just some pictures of what I just talked about. On the top left is a picture of a little boy with Treacher Collins. So you can see the relatively flat affect of the face, the slanted eyes, and the ears not being completely formed. Also, you can kind of notice that his bottom jaw kind of jets out a little bit more, causing that disalignment between the top row of teeth and the bottom row. So this could be a underbite situation. Then on the bottom there of the eye is just a picture of the notched lid. I didn't know what that was before doing this project, so I thought that it would be important just to throw that in there. And then above that are the different grades of microtia that can be seen. We kind of went over this in pediatrics, but I thought that it might be a good review here. So I'll just go through them real quickly. So grade 1 is a little bit smaller pinna than normal, but typically has normal anatomy that can still be seen. Grade 2 is somewhat normal anatomy. Lower part of the ear could look a little bit different. The ear canal can either be normal or stenotic or atretic. For grade 3, it's deemed as like the peanut-shaped ear, so completely closed, so an atretic ear canal. And then grade 4 being no remnants of a pinna and completely atretic ear canal. So for the risk factors, there's not really a specific risk factor other than receiving a dominant allele from one parent or two recessive alleles from both parents for the symptoms to be presented. So for a dominant, you have a 50% risk factor of receiving those alleles, or recessive, you have a 25% risk factor of obtaining those alleles. And then on the screen, I just have some references of autosomal dominant and autosomal recessive kind of characteristics about how things are passed. So just a little review if you need it. So for medical management for Treacher-Collins syndrome, it includes many different types of surgeries for the face. So the surgeries go from firstborn till later in adulthood. One of the first surgeries that could be completed is a tracheostomy. This is due to the tongue obstruction on the pharynx, enabling the infant to breathe. This is considered obviously an emergency surgery and would be completed as soon as the baby is born. In the very early stages of life, the infant can have eyelid colomboma and cleft palate surgery. So eyelid colomboma is a thickened eyelid, so the surgery would be to remove some of the thick skin that surrounds the eye. Cleft palate surgery helps mend the soft palate. This is important for speech development, articulation, and swallowing, mandibular or maxillomandibular osteotomies, which aligns the jaw and or the maxilla to be straight. So this helps with also improving airway passage. Orthodonture to correct for overbite and underbite. Reconstruction of the pinna or EAC can be completed at age 5 to 7 years old. All of the surgeries should be completed with bone construction coming first and soft tissue coming after. The main regions of soft tissue that is most common for reconstruction is the external ears, the eyelid structures, preauricular cheek skin, and temporal fossa. However, every patient is individual with individual needs and varying degrees of needed surgeries. Also, some of these surgeries, like the tracheostomy, that is important to do, but some of the plastic surgery or facial reconstruction are not always necessary, medically necessary, and would be more for the patient just for confidence purposes or just wanting to do that. And some patients opt not to, and that's okay too, but just referring back to case-by-case situation, but these are some of the treatments or medical managements that can be completed. So for audiological treatment, in a study by Rosa et al. In 2015, they evaluated 18 children ages 1 month to 14 years with the mean age of 1.7 years with Treacher-Collins syndrome. The results indicate that 78% of them have atresia, 22% have stenosis, 44% have dysplasia of the ossicles, and 55% have an absence of ossicles. 100% of these patients in this study have a conductive hearing loss of some degree. So also to note in other resources that I have put in the worksite at the end of this page, but is that about 50% of these individuals, of these patients with Treacher-Collins, have a conductive hearing loss. So it's about 50%. So even though this study said 100% of their patients had a conductive hearing loss, just to note that they could not have a hearing loss as well. And it's typically not mixed or sensory neural, that's extremely rare. So with the absence or lack of a pinna combined with atretic and stenotic ear canals, a traditional hearing aid would not be the best option for them. So with that being said, a bone conduction device is typically the route that is taken for audiological treatment for these patients. In the early stages of life, a soft band with the conductor attached to it would be the best option. Surgery for an osseo-integrated bone conduction hearing device can take place after the age of 5 years old. However, it's noted that in an article by Hager in 2007 that this is a challenging population to have this surgery because of their abnormal skull contour. This makes them susceptible to trauma and more difficulties post-operation about 15% of the time. Therefore, surgeons try to do these surgeries with 2 fixture implants, one being a backup, so they don't have to go back in and redo the surgery. Another option for a bone conduction hearing device would be the use of a magnet abutment to attach it to the skull. A newer option for pediatrics instead of the use of a soft band would be the use of the adhere. So the one that we tried in class a few weeks ago, it has the sticker on the back and is removable. So this is also a pretty useful option for pediatrics that eliminates the soft band as well. So just some more options for them. Here are some pictures that supplement what I just talked about. On the top left, we have the adhere. So it's just placed behind the little boy's ear, and there's different color options as well. Then on the bottom, we have the magnet abutment. So the magnet on the right will slip underneath the skin, and that's how it will be attached to the skull. And then there is the child up on the right with bilateral bone conduction devices attached to a soft band, which matches her cute little overalls. And then just on the bottom is just some different power types of bone conduction devices in different grades of power. So now we'll switch gears to talking about Stickler syndrome. So for the etiology and pathogenesis, it is an autosomal dominant disorder. This syndrome affects the connective tissue that is involved in the eye, ear, facial development, and musculoskeletal system. There are 5 mutations that affect the collagen that is present in this area of the face and musculoskeletal system. COL2A1 is the most common mutation, with it being 80 to 90% of the cases, followed by COL11A1, which is 10 to 20% of the cases. COL2A1 has the gene which produces the most type 2 collagen. This type of collagen is found in connective tissues and also seen in the inner ear. COL2A1 is considered type 1 Stickler syndrome, which it has the highest chance of retinal detachment. Type 2 Stickler syndrome is with the gene mutation of COL11A1, which also includes eye abnormalities. It has been shown that there is more of a chance for hearing loss in types 2 and 3 as opposed to 1, meaning that type 1 has a mild hearing loss in the high frequencies, and type 2 to 3 has more as more of a severe type of hearing loss that can encompass more than just the high frequencies. The remaining mutations are extremely rare, and only a few cases have been documented thus far. So here's a picture of a little boy with Stickler syndrome. You can just kind of see the flattened features on the face. So for the epidemiology, there are about 1 in 7,500 to 9,000 recorded live births that are diagnosed with Stickler syndrome. This is a congenital syndrome, and it is genetically heterogeneous condition. This means that there is one gene that is mutated, but it can be expressed in a multitude of ways. So this relates to the gene mutations for Stickler syndrome being one set of mutations, but they can be expressed in different areas such as their eyes and ears, so relating to their vision or their hearing loss. For their phenotype, it's typically a flat facial profile, which is caused from the lack of collagen that is present with the gene mutations, which alters the mid-face hypoplasia, which incorporates the maxilla and nasal bridge. I'll just go back 1 second. You can kind of notice in this picture that the nasal bridge is completely flat. So that's a large telltale sign of Stickler syndrome. So other presentations of Stickler syndrome include an underdeveloped jaw, and sometimes the presence of cleft palate have been reported. Other aspects of Stickler include early onset of osteoarthritis, short stature, and hypermobile joints. For ocular abnormalities, these are predominantly in COL2A1 and COL11A1. These type of mutations can have myopia, which is nearsightedness, retinal abnormalities such as detachment, and cataracts. As far as hearing loss goes, when hearing loss is present in type COL2A1, it is going to start out as a mild hearing loss, which will progress, but not very rapidly. So pretty similar to the rate of presbycusis. For hearing loss that is tied to the mutation COL11A2 and COL11A1, it is much more severe, which could be high frequency or anything in between. So it can encompass more frequencies than the other mutation. And this is also more likely to be progressive, as in a faster rate of this progressive hearing loss as opposed to the other one that is more like a presbycusis type style. Lastly, they typically have hypermobile tympanic membranes due to the lack of collagen that they have in their system. So there's a picture of a little girl with some glasses on. So for the risk factors, they're very similar to Treacher Collins, as in there's not really like one significant risk factor other than it being an autosomal dominant and autosomal recessive gene, and the child obtaining one of the dominant alleles or two for the recessive allele. Types 1 to 3 are autosomal dominant, and types 4 to 5 are autosomal recessive. The autosomal recessive types are extremely rare and hardly expressed only in a few cases that have been diagnosed with these types, like I have mentioned before. So besides these mutations that are already stated, a new mutation can be formed that would be considered Stickler syndrome, but these patients do not have any family history of Stickler syndrome in their family line. So it's important to get genetically tested. And here's just another diagram of some recessive genes. So for medical management for Stickler syndrome, this syndrome requires a team of professionals, a multidisciplinary approach to treating and medically managing these children. Each patient with Stickler syndrome is going to present differently based on their mutation or how they are presenting with the mutation. Some are mild cases and some are more severe. Once the diagnosis has been established, it's recommended that families go to a geneticist to better understand the syndrome and how it has manifested, especially if it's a new mutation and it comes out of nowhere. It's good to have that counseling for patients and for parents, more importantly. Next, it's important to provide the child with proper glasses or contacts to correct for their myopia or nearsightedness. Patients with Stickler syndrome have a higher chance of a detached retina, so it's highly recommended that they avoid contact sports throughout their life. In some cases, doctors might suggest doing a prophylactic cryotherapy to reduce the chance of retinal detachment. The removal of cataracts is also an option if the patient suffers from such. Because of the respiratory problems that these patients have, a tracheostomy to support respiration is a very common medical management option for these patients and is typically seen. Cleft palate surgery and micrognathia, sorry if I didn't pronounce that right, can be done to also assist with respiratory difficulties. Physical therapy could be completed because of their hypermobile joints and orthodonture to correct any dental malalignment. Lastly, having a conductive hearing loss can be common in these children because they do have they could have a history of recurrent otitis media. So tube placement can be an option, just as it is for other children as well. So just something else to keep in mind. So for audiological treatment, it's pretty traditional to other children with hearing loss. We would fit them with an air conduction hearing aid, BTE with an ear mold with targets matched to DSL-5 and omnidirectional settings on to support incidental learning. We would like to monitor these children every 3 months, then 6 months, and finally a year since it is progressive. Once the hearing loss seems to have slowed down in progression or has not progressed further in a significant amount of time, an annual hearing test can be implemented. Hearing aid checks should be completed every 3 months to ensure that the devices are providing enough gain, benefit, working properly, and to change the tubing out. Also, in the early stages of life, new ear molds are to be made pretty regularly since they are growing so fast. Okay, so now we'll change gears again and go through the case study. So I'll go through the case history and some results that have been shown for this girl, and then talk about what the syndrome is. So the 13-year-old female presents with the following case history. She was born full term with no birth or pregnancy complications. However, she was transferred to the neonatal intensive care unit for 1 month. She has bilateral atresia and grade 3 microtia. She has slanted eyes with notched lower eyelids and underdeveloped facial features. For the next 18 months, she was tube fed and had a feeding tube because she had trouble with feeding and had swallowing issues. She also had a constricted airway, but she was still had the ability to breathe on her own, but was closely monitored for that. So at age 4 years old, she had an ABR completed on her. Only bone conduction could be completed due to both ear canals having atresia. At this time, these results suggested a maximal severe conductive hearing loss bilaterally with and then also to note with a bone conduction ABR, the results are going to be less pretty. The morphology is going to be more poor when compared to an air conduction signal. So the results that are on the screen, they're not from this case, but I just wanted to highlight kind of what the best case scenario of a bone conduction click would look like. It still doesn't look the best, but still able to notice wave 5, how it dips down and comes back up. Always want to have repeatability and enough sweeps to ensure that that is the correct response. So then at age 5, let me back up. So then at this point, she was fit with a Baja unilaterally on a soft band. So then at age 5, CPA was performed under headphones, which revealed the right ear that having a moderate conductive hearing loss and the left ear having a severe conductive hearing loss. SRT and PTA are in agreement with each other, and WRS was excellent when presented at an elevated conversational level. They didn't note exactly what that is, but I'm assuming it's around 70 dB. So this is the audio. You can just ignore the aided thresholds for now. And then, so you see the bone line, then normal limits, and then the air conduction signals are more elevated. So, what do we think the syndrome is? So, if you thought Treacher-Collins syndrome, you are correct. So, for management, at age 7, she had surgery to receive her osseo-integrated Baja device unilaterally. Aided responses, which were on the last audio, this one, showed that she's hearing within a mild hearing range, with an SRT being 20 dB HL. They also did aided speech and noise testing. Excuse me. They didn't say what test exactly, but she got 80% correct on that. Currently now, at the age of 13, she uses an FM system in school sometimes, and she also has an IEP. She states that she is able to keep up with the material, and parents note that she is doing well in school. She has minimal accommodations as well. She is going to have jaw surgery soon, and it is recommended that her speech therapist should determine if additional therapy should be completed after the jaw surgery is completed. She already is in speech therapy regularly, but just some additional help after the jaw surgery takes place. She also goes to Hit It, which is a support group program for young teens to learn about how to advocate for themselves and their hearing loss. I just thought that this was important to note that, when we are seeing these children or these teenagers now, they need some extra help to realize that it's okay to use their FM system, or it's okay to wear their devices, and just teaching them different tools and ways to go about people asking about it, or them asking for what they need at school. So I thought it was neat reading that. She goes back to the audiologist every 6 months to get an updated audio and a hearing aid check. It's still recommended that the parents obtain genetic testing because they don't have a family history of Treacher-Collins syndrome. So this could either be a new mutation that has manifested, or it is she received 2 recessive alleles from excuse me from her parents. So this is a case of Treacher-Collins syndrome and not Stickler syndrome. And here are just some reasons as to why it was Treacher's and not Stickler. So one being that she had bilateral atresia with grade 3 microtia, which is very typical in a Treacher-Collins child, or a child with Treacher-Collins, excuse me. And so it's also symmetrical, and that's a good differential diagnosis terms for diagnosing someone with Treacher-Collins syndrome. Also, Stickler syndrome, typically they do not present with microtia, and so this was one of the reasons why Stickler was ruled out. Also, Treacher-Collins syndrome has a conductive hearing loss. That's very indicative of it. So she presented with a conductive hearing loss, and with Stickler syndrome, they can have, otitis media when they're young, and but it's not going to be a persistent conductive loss as opposed to Treacher-Collins. So I feel like this was one of the bigger ones as to why it was one and not the other. Kind of a good way to rule it out. Also, she is not nearsighted. Her vision is okay, and with Stickler syndrome, them having myopia is extremely common, and that's something that a lot of patients with Stickler syndrome have to wear glasses, and that's a typical symptom. Also, she had slanted eyes and notched eyelids, which is pretty common in Treacher-Collins syndrome and not in Stickler syndrome. So overall, I think the main takeaways for why Treacher-Collins syndrome can be differentiated from Stickler syndrome would be the type of hearing loss and the symmetrical facial anomalies that can be present. Yes, they both do have the flattened facial features, but as far as, the slanted eyes and the malformed pinnas, this could be a way to differentially diagnose a patient. But at the end of the day, also, it's important to do genetic testing to really make sure which one it is, since they can both present with very mild symptoms. And so it's important to understand where it manifested from, and to get a correct diagnosis, even if it's at a mild stage. So we are all done. Here's my works cited.